Good evening, sir. Good evening, all the aspirants. So, shall we start the session?
Okay, thank you.
Uh, yes, sir. So, aspirants, this is going to be a CCS session and a really interactive session. And the speaker that we have here is Fathy Elshazly, sir. So, you may take over. Thank you.
Thank you so much, Fatima. Welcome again, and I hope that your studying is going well, and you are well prepared for the exam in next November, hopefully. My plan was to do a long case and short case, but the organizers asked me just to make it 1 hour today. So, because I know it's too late now in the eastern part of the world, so we'll start with the long case, and if we have time, then we can go quickly with the short case as well. So, as I mentioned before, this is supposed to be interactive session. It's useless if you're not going to interact, if you're not going to try to answer the questions, because that's what it's all about, and that's what matters actually. That we have to practice. The exam is not about knowledge. This exam is not about knowledge. It's about how to show to the examiners committee that you have experience, that you know what you're doing, and you are safe to practice intensive care medicine in Europe. So I would like one of you volunteers now to start reading the scenario, please. So, any volunteer?
Yes, I will volunteer.
Dr. John, okay. Would you mind reading the scenario, please? Usually you have 1 minute in the exam to read the scenario, okay? Usually they give, I think, more than 1 minute, about 5 minutes to read the scenario or so, and then they start asking the questions. So, would you mind reading the scenario loudly, sir? Just the vignette. Don't care about the numbers, about the numbers, but just read the vignette and then have 30 seconds to think about it, and then when you are ready to start asking the questions, we will start. Okay.
All right, sir. A
Thank you.
28-year-old male, height 1.6 meters, weight 60 kilograms, previously healthy man, presents to the emergency department with rapidly progressive shortness of breath, high fever, and hemoptysis. History. He has 1 week ago, he had a flu-like illness. He smokes occasionally, but no past medical history, no recent travels, and no immunosuppression. Okay. Should I go ahead with the physical?
Okay.
Okay. On arrival, his temperature was 39.5, heart rate was 132, blood pressure 88/50, respiratory rate was 30, SpO2 was 88% on 15 liters using non-rebreather mask. He was fully conscious, GCS 15/15. And physical examination shows that he had diffuse crackles, both lungs, with pink frothy sputum, with blood streaks, mottled skin, and delayed capillary refill. Okay, so the X-ray is as shown on our right.
Would you mind interpreting the chest X-ray for us, please? But ignore the tube, which you can find it. Ignore the endotracheal tube, but just let us see your interpretation of the chest X-ray.
The chest X-ray shows woolly infiltrates, that is woolly dense infiltrates in the apical region, right apical region, as well as in the right lower and left mid-zonal areas of the lungs. Woolly opacities.
Okay. Yeah. Okay, based on the chest X-ray, based on the clinical symptoms and sign, and based on those numbers which you are seeing, what's your differential diagnosis?
Well, I'll make a start with lobar pneumonias. Yes, lobar pneumonia, and you might also have
Do you think it's loop or pneumonia? Is it confined to one loop, or it is bilateral pneumonia? Bilateral bronchopneumonia.
Okay, yeah, bilateral pneumonia, I would rather say.
Okay,
Bilateral.
what do you think the cause of this pneumonia? What else other than pneumonia first? Before, what else other than pneumonia?
What are the
other pneumonia? Bronchopneumonia is your first official diagnosis. What are the other causes of this picture and this chest X-ray?
Well, it may be viral in origin, and it's also possibly fungal. Fungal pneumonia is also possible from this this picture.
Okay, other than infectious causes, what else? Any other non-infectious causes you can think about here?
Perhaps pneumoconiosis.
Pneumoconiosis, okay.
Volume overload.
Volume overload, yes, okay. What else?
COPD.
Maybe aspirator.
COPD, asthmaticus, yeah, status. Asthmaticus.
What else?
Bronchiectasis. Malignancy.
Okay.
Then aspiration, right side
Goodpasture syndrome as well, because the kidneys are also involved.
Great. Goodpasture syndrome, or any cause of vasculitis, or autoimmune, because here we can see that he's got pinkish frothy sputum,
pulmonary hemorrhage,
blood streaks, there is thrombocytopenia, there is neutropenia. So all of this, pulmonary hemorrhage, alveolar hemorrhage, all this can be a differential diagnosis. Okay. So what are you going to do next? We need another one. Any other volunteer other than Dr. John? Shiam, okay, Shiam. You can go, you can carry on, please. Yeah. What would you do next?
No, I can't continue. I can say something.
Okay, please. Okay, Dr.
Okay.
John.
Now, from the presentation, this patient is in hypoxemic respiratory failure, and so one of the first things I would do is to intubate him and put him on mechanical ventilation. I would also like to. There's also sign of sepsis, which is likely to be of this pneumonic origin. So I would like to send blood cultures and sputum aspirate for both culture and sensitivity, and then start empirical antibiotics for him, while waiting for the results of the cultures. Then his blood pressure is low, so I would also like to resuscitate with maybe 30 mL per kg of fluid. If the blood pressure is not controlled, then I will start NORAD infusion with a target MAP of 65. That will be.
How much flows are you going to give him? How much flows are you going to give him? How much flows are you going to give him?
With the sepsis, for initial resuscitation, I'll give 30 mL per kg over the next 1 hour.
What kind of fluids?
I will go for Ringer's lactate.
Okay. Okay. You said that you are going to intubate him. Why you haven't thought about using other non-invasive measures?
About the,
anyone else would like to answer the question?
So he's in neutropenia sepsis at the moment.
88% on NRBM, 100%.
Okay, let's make it organized so that we can all get okay. So John, you want to talk? You want to talk? You want to say answer the question before I go carry on with another candidate?
Yeah, actually, NIV is since the patient is fully conscious, because the GCS is 15/15. But one of the reasons why I wouldn't want to go for NIV for this patient is because of his hemodynamic state. He's hypotensive, and I think it will be best to to go straight to endotracheal intubation in this patient with hypo, even though his GCS is 15/15, but he's in shock, you know, he's in shock, you know, from septic shock, from what I can see.
Anything else other than NIV would you like to we can use here?
Okay,
high flow nasal
cannula. Who said that?
So yes, sir.
Who's this?
Nafisa.
Nafisa. Okay, Nafisa. You said high flow nasal cannula. What are the indicators of failure of high flow nasal cannula in this kind of patient?
If we can use for high flow nasal cannula if the patient is not improving or desaturated, or there is a then we consider from the advanced modalities.
So if oxygen saturation is not improving, or what else? What other clinical signs?
Not improving or desaturating.
Okay, that's what we said there. What else?
Okay. So the patient is neutropenic, and also because he's on 15 liters of oxygen. So currently, I would initially want to try either high flow nasal cannula or CPAP for that matter, because consider the patient is immunosuppressed because of the neutropenia. I would definitely go for non-invasive first before considering invasive ventilation in this patient especially.
So you would go first with non-invasive, right?
Yeah. Yes.
So
exactly.
What's for example, because he's neutropenic and he has got might be valvular hemorrhage.
High flow doesn't have much of
what's the first choice for you? Yeah.
So high flow doesn't have much of a mortality benefit compared to CPAP. So I would try CPAP in him, and also I would like to scan his lungs on the way to ITU, because obviously it looks like he possibly has a right upper lobe collapse versus a tumor. So the trachea was not deviated anywhere. So I would go more towards a collapse of the right upper zone to see if a bronchoscopy can be done after I intubate the patient, in case if that's what's causing the hypoxia.
Anyone else would like to add anything? Okay, so whenever they ask you what to do next, you have to go first as systemic as you can. Go with the ABCDE. Anything regarding resuscitation or dealing with acute patient, in order not to forget anything, and go systematic, because actually the examiners have got some sort of checklist in front of them, just boxes they have to check. If you don't see anything from what they in front of their box, they cannot give you the mark for it. So in order to avoid, and all of us, no one will take the full mark. No one, even the examiners themselves or the people who put the question or that wrote the question themselves, if they are going to take the exam, they are not going to take the full mark. And they will not be able to remember everything written there. But at least in order to reduce what you are going to forget as much as you can, try to go systematic. And the best way to go systematic, like we do every day in our daily practice, is to go A, B, C, D, E. So airway and breathing, as mentioned by John, prepare for intubation, and prepare the ventilator just in case if you have need to intubate him. You can use non-invasive. You can try non-invasive method if the clinical situation allows you, whether non-invasive or nasal high flow. Now it's obviously nasal high flow is more preferable, especially because it's more comfortable to the patient, and especially of course because of I know that the beep which is being given by the NIV is much higher than that which is given by the nasal high flow. But in this patient, you wouldn't like to start NIV, especially in the presence of bleeding and blood streaks, and we are suspecting some sort of alveolar or pulmonary hemorrhage in this patient. So I would rather, if I'm going to choose nasal high flow, if I'm going to choose non-invasive method, I'll go with nasal high flow, but the intubation should be standby, and we should have very low threshold for intubation, just in case if the patient is not improving. How we are going to assess the improvement of this nasal high flow will go next. Circulation, as mentioned by John, cautious fluid 20 to 30 mL per kg, isotonic crystalloids, like Ringer's lactate, and early norepinephrine, or any sort of peripheral vasopressors. Of course, you can give norepinephrine peripherally in low dose, but whatever you do, yes, you can give norepinephrine peripherally low dose, but you have to respect the policy of the hospital you are working in. And so if you are going to use, say, vasopressor, you have to say whether mix, for example, phenylephrine, metraminol, which is, I know metraminol is not found in a lot of other countries, but it's found here in UK and in Australia, so, and Ireland. So maybe, so start always with phenylephrine. So because phenylephrine is available all over the world. So start phenylephrine or low dose norepinephrine if the hospital policy allows me to. If the hospital policy allows me to. Because whatever you do, you have to respect and honor the protocols and the policy of the hospital you are working in or the country you are working in. Okay? So you can say early vasopressors which can be initiated in peripherally. Okay? Until the patient is being stabilized or until I can do the central line in safely. Okay, because the central line, if it's going to be done in emergent situation, then the risk of complications and the risk of infection are going to be much, much higher than that if it's going to be in a controlled environment, like intensive care or something. Okay, so, and these patients obviously have respiratory distress, and it would be very difficult for them to lie flat in order to be able to insert the central line. So yes, you can use the vasopressors peripherally, and you give an example whether phenylephrine or noradrenaline with respect to the local policies and protocols. Antibiotics, we'll start with broad-spectrum antibiotics like tazobactam, for example, etazocin, and we have to think about MRSA cover as well. You might think about whether linezolid or vancomycin, and whether or not you can use toxin suppression plus atypical. Some people, I know this X-ray is a little bit vague, but at least we can start now with tazocin and for something for the atypical like azithromycin or moxifloxacillin or whatever quinolones usually, or macrolides, which can cover the atypical as well, because he's a young chap, young man, he's presenting now with severe pneumonia, and so covering the atypical would be wise in this one. And of course, you always have to mention to them the sepsis bundle or surviving sepsis campaign, because it is generated from the European Society of Intensive Care in the first hour. You have always, there are some words which you like to hear in the context of your answer, especially those which includes guidelines which were written by the European Society of Intensive Care, like cultures, lactate, antibiotics within 1 hour. Okay, with respect to the sepsis bundle of the Survive Sepsis campaign. So the next question which I asked, what criteria would you use to determine the failure of nasal high flow? And this question can be asked to you. Nafisa gave a very pragmatic answer, which is right. The first thing is persistent or worsening hypoxemia, increased respiratory tachypnea, signs of respiratory distress like use of accessory muscles, nasal flaring, paradoxical breathing, hemodynamic instability, hypotension, or need for vasopressors. That's an indicator, although it is not, cannot be used alone, but it's an indicator that most probably nasal high flow might fail. Altered mental status, like any other non-invasive method, confusion, agitation, decreased consciousness, non-cooperative patient, or need for intubation ability to maintain adequate oxygenation or ventilation. And there are objective scores. Those objective scores evidence are not yet solid and are mainly being used in the emergency department, not the ICU. But predictive scores like ROX index, which is the ratio of oxygen saturation to FiO2 to respiratory rate, which when it is less than 3.85, then it's a predictive of failure. Okay, you can Google it or look for it, what's called ROX index. And there are another severity scores, which is CT severity scores, which is greater triangle involvement on imaging as associated with worse outcome and failure of nasal high flow as well. There are other methods, there are other scores. SOFA score as well have been used, but not so much evidence about it. You can use the other biomarkers like CRP, interleukin, and all of this with poor evidence and are non-practical actually to use them in emergency or critical situations. Okay. You mentioned that you're going to intubate the patient. Who's going to answer the next question?
Should I start antiviral, sir?
So, you can, as if you're, but usually I would rather ask the microbiologist or the infectious disease first before starting antiviral. It depends upon the clinical situation. For example, if it is an outbreak of flu, or for example, flu season, and there's an outbreak now, or some sort of epidemic in the society, there will be some sort of temporary policy which will allow you to do so, but don't make it a routine. And that's why, and you remind me now that I forgot, I'm sorry for that, that one of your screening investigations, what you should do as well, on seeing the patient, you should ask for a typical screen, for example, Legionella in urine, pneumococci in urine, and the other, what's called extended viral screening, which include adenovirus, COVID, respiratory syncytial virus, flu, all of this is called extended viral screening, okay? Especially during this time, during autumn or winter times, this usually being seen for any patient who are presented with pneumonia or acute respiratory failure due to infectious cause, okay? So extended viral screening and atypical infection as well. So the next question, who is going to answer it?
Yes, sir.
Who?
Myself, Pankaj. Dr. Pankaj.
Okay, so how are we going to intubate the patient?
Sir, for intubating the patient, we will use a drug-assisted intubation along with rapid sequence intubation, where we will use etomidate or ketamine along with succinylcholine if potassium is within the normal threshold. And we will
if it's
also
high, if it is high, what are you going to use? If it is
then we can use rocuronium. Then we can use rocuronium at the rate of 1.5 milligram per kg body weight.
Okay.
And we will also be ready with any mishap if happen, considering difficult airway cart along with us if possible. And so we will use in this case, yes, patient is hypotensive, so we can use ketamine at the rate of 2 milligram per kg body weight, followed by rocuronium at the rate of 1.5 milligram per kg body weight, along with required pressure. And once our tube is in place, we will cross-check confirm the position of the tube, and then we will release the required pressure, and then we will connect to the ventilator.
And how you confirm that the tube is in?
With the help of EtCO2 monitoring.
Great. Okay. Great. That's very good answer, actually. But as I mentioned before, in last month when we had our first CCS session, always just mention things that you like to hear from you. This is a very safe method, actually, a very safe method, and I think that you would take the full mark out of it. But just mention some things that they like to hear from you, like intubation checklist. Okay, if they say that's an intubation checklist, and so that I wouldn't forget anything and prepare the team. And this you don't have to, of course, to memorize all of this, but just memorize the titles. Prepare the patient, prepare the equipment, prepare the team, prepare for difficult intubation. Okay, so yes.
So yes, sir. Yes. So means we have to take we have to also answer that pre-intubation preparation, intra-intubation preparation, and post-intubation preparation. We all have to.
Great. That's it. Great. And so, in order not to forget all of this, because in emergency situation or after midnight, you might forget. Every one of us might forget and might, or maybe you are busy, maybe you are tired. So, in order to prevent any kind of personal discrepancies, always you tell them we'll do the checklist. then you will say, and after this doing the checklist, you can say whatever you want to say. But start always with saying the checklist. They like to hear this word, okay, to prove that you are a safe physician, okay? And then go as you said exactly, pre-intubation, intubation, and post-intubation, and go with the drug-assisted intubation or rapid sequence intubation, whatever you said. Cricoid pressure, some people like it, some people don't like it. It was mentioned sometimes in the guidelines, some guidelines, other guidelines don't mention it. The issue about intubation, there is no unified guidelines for intubation. For example, there is no European guidelines for intubation. Even the European Society of Anesthesia and Intensive Care, the EDIC, not the SICM, the EDIC, don't have guidelines for intubation except for children and infants. They do not have guidelines for intubation of the adults or critically ill patients. There are local guidelines in each country. They have their own local guidelines. And of course, the most acceptable or most widely used in Europe, it's called what's the Difficult Airway Society Guidelines, which is generated, which was generated here in UK. And of course, there is as well the American Society of Anesthesiology guidelines. This can be used as well. And they are not, and the European Society of Intensive Care, they are not adopting or recommending any specific guidelines. The only issue that they want you to be safe while you are performing this kind of procedure. Okay. Yeah.
Sir, before telling anything, can we quote the guideline? Since I was quoting the guideline of DAS guideline, that is Difficult Airway Society guideline. So before starting our answer, can we quote the guideline, or will it be?
You can, but I don't think that the model answer in front of them would contain DAS guidelines or whatever. But you can, of course. They respect that. They respect, for example, that you came from England. You can mention the guidelines of the or the protocols of the country you are working in, especially if it is an European country. And so you can mention DAS guidelines or Difficult Airway Society. And I recommend when you say DAS, say Difficult Airway Society guidelines. So because not all the examiners are aware of DAS actually. Some of those examiners from Italy, some of them from Greece, some of them from Portugal, some of them from Spain, others from Germany. Not all of them are aware what's called DAS means. Okay, so try always to deviate away from the using acronyms. Okay, say Difficult Airway Society or DAS guidelines, and use using their checklist, for example. Okay, and then and their preparation for Plan A, Plan B, Plan C, and Plan D difficult airway protocols. You can say that. Of course, we mentioned this before in our lecture, so I'm not going to spend too much time on the checklist or the tracheal intubation or the guidelines of intubation. This is the DAS guidelines of critical ill intubation. You can run through it. It's very simple, not complicated, and very practical. Unlike of the American Society of American College of Anesthesia, it's a little bit complicated, but this is very simple and can be read in 5 minutes. And you don't have to memorize it, but at least go through it, and it will stick in your mind. It's not difficult at all. Okay, so after you intubated the patient safely, and of course, as mentioned by John, don't forget before intubation, that's to prepare vasopressor standby before intubating the patient, because those kind of patients, they may collapse after intubation because of the positive pressure ventilation. So always prepare vasopressor standby. Okay. For example, even if you have whether phenylephrine or noradrenaline infusion, just to be prepared standby, because I mentioned that those patients may collapse after intubation. Okay, so you intubated the patient successfully and ventilated, and now the patient is ventilated, sedated via propofol 240 milligram per hour and fentanyl 50 mics per hour. What other measures would you take to improve the oxygenation and treat the primary disease? So who next? Looking for another one. Sorry. Dr. Muhammad, would you like to answer this question?
Sir, we will follow lung protective ventilation protocol. We will start with 6 ml per kg body weight.
Okay, Pankaj, you can go. Pankaj Kumar, okay. Lung protective ventilation, okay. What else? What are the lung protective ventilation?
We can use
what are the
muscle.
sorry, Dr. Muhammad, what are the lung protective ventilation? Pankaj, could you answer, please?
Low tidal volume, high respiratory rate.
How low? How low is it?
It is 6 ml per kg body weight.
Okay.
6 ml
4
per
to
kg
6
body.
ml per kg predicted body weight.
Okay, I need one bus to answer, one only to answer, please. Pankaj, you started it. Would
Yes,
you
sir.
like to complete it? Okay. So, what are the tidal volume 6 ml per kg? What else? Other elements of lung protective strategy, please.
And optimizing the PEEP so that our PaO2 is more than 60%, 60 mmSg. And
So can I answer?
And if patient is not if patient is asynchronous with the ventilator, then we can also go for muscle relaxation. That is ARMA trial.
So can I answer?
Okay, Nafiza, okay.
Sir, for the patient for the lung ventilation, we prefer low tidal volume 4 to 5 ml per kg in the positive body weight, and my target will be the blood pressure less than 30 centimeter of water. I start from the
I cannot hear. The voice is not clear. Sorry, the voice is not clear. I heard 4 to 5 ml per kg. I couldn't hear what else.
And my target blood pressure will be less than 30 centimeter of water. I start with the FI 200, and I will try to strike it below 50 FI to 50%. And I like to choose the titrable PEEP. So can I reduce the FI2 for this patient? And I try to avoid the asynchrony of the patient. I like to prefer adequate sedation, and if it is needed, I go for the neuromuscular blocking agent for this patient to prevent the any asynchrony.
Okay. What kind of pressure would you need to be less than 30?
Plateau pressure.
Plateau pressure. Okay.
And also driving pressure we also prefer less than 14 centimeter of water.
14. Okay. 14 or 40?
14.
14. Yes, great. Okay, it can be 15. I know that you are a very bit conservative, Dr. Nafiza, but you can be 4 to 6 mils per kg is acceptable, not 5. 6 is acceptable, and driving pressure less than 15 can be acceptable as well. But great, you know what is. And I'm regarding the beep. You can just say high beep in the answer, because there are some words which you don't like in the SICM. For example, most of us do the incremental beep in our practice. In our daily practice, we are increasing the beep gradually according to the patient tolerance. But they don't like this word in because it's against their own recommendation. Their own recommendation is against incremental beep.
For optimizing the PEEP, we can follow the ArtsNet chart of the PEEP versus FiO2, and then
you can say whatever you want, whether the arsenic chart, or you can use the low inflection point using pressure volume curve or whatever you can say. And you can use and you can tell them, for example, if you want to manipulate the examiner, you say, I will increase the beep gradually according to the patient tolerance and hemodynamic instability. But don't say the word incremental beep. Just don't say the word incremental beep. You can say, you can manipulate whatever the answer, but don't say something that might annoy them a little bit. Okay, even if they are doing this every day in their practice. Yeah.
Okay, so won't it be better to simply say that you determine the optimum PEEP for this patient?
Yes. Okay. Yes. Regarding the optimum, you can say it. That's a good word as well. That's a good word to say. Okay. I don't think that going to go deep, because this is theoretical application. This exam is not about theoretical. It's about how you are going to clinically apply your knowledge into the patient, and how to determine, how to show them that you are a safe physician. So we don't have to go a lot into details here. But as you mentioned, early prone positioning, lung protective strategies that you mentioned, neuromuscular blocker for refractory hypoxemia, and conservative fluid balance after resuscitation.
Recruitment maneuvers and permissive hypercapnia.
Okay, these recruitment maneuvers and permissive hypercapnia is part of the lung protective strategy. Okay, recruitment maneuvers are, it's not, there are no evidence about it. They don't recommend it, nor not recommending it. So they are not either rejecting it or recommending it. Okay, so this is part of the options. If you see the guidelines of SICM regarding the ventilatory strategies, whether in COVID or in any other ARDS, or even in ARDS.net, which is the main reference for any ARDS management guidelines, they are not recommending with or against the recruitment maneuvers. Because obviously, if you are going to do a recruitment, then most probably the patient is in critically ill condition and severely and in very arrested status. So yes, he's very deteriorating very rapidly, or he's in refractory sort of hypoxemia. So they allowing you to do whatever you want, but according to the studies, those recruitment maneuvers haven't improved the mortality. Okay, the only thing which is have improved the mortality among all the recommendations, lung protective strategies, early prone positioning, and neuromuscular blockage for about 48 hours. Okay, so this is according, and for example, when they are the questions might take here different pathway. For example, if you say early proning position, where they are going to ask you, when are you going to start proning for this patient?
If PF ratio is less than 150. If PF ratio is less than 150.
What's your evidence on that?
Sir, if the
Bruseva trial, that's it. That's enough. So neuromuscular blockage for refractory hypoxemia. They might use what's your evidence for that?
Accuracy trial.
Accuracy trial. That's it. That's enough.
Accuracy trial.
Accuracy trial. That's enough. That's enough. Okay. And the conservative fluid balance are targeting zero balance or slightly negative balance. Yes. Exactly. And as mentioned, for early antibiotic administration according to the sepsis bond. Okay. So try to make it simple as much as you can. Don't speak too much. Don't go into a lot of complications. Just try to be simple and reduce the and just answer, be pragmatic and objective in answering your questions. Okay.
Non-conventional
details. Yes. Sorry, Dr. Muhammad.
Non-conventional modes of ventilation.
The APRV. Okay. The same answer applies to the recruitment. Non-conventional modes like APRV, for example, is not evidence-based. If the patient is deteriorating, and he's not responding to the lung protective strategy or those measures like early proning, or there is contraindication to proning or neuromuscular blockage, then you can go with you can suggest something else. And usually, if they're going to ask this question, they're going to ask, what other options are you going to do now?
Yes, I'm just mentioning.
So the patient is not improving. Yes, the patient is not improving. What are the options are you going to do now? For example, then you might say, yes, refer to ECMO. You might say carbon dioxide removal. Carbon dioxide removal. Are you aware of the carbon dioxide removal?
ECOR, yes.
ECOR, yes. And then you mention APRV, non-conventional method like APRV or high frequency APRV, for example. Okay. Then you can say that, but first mention ECMO first, refer to ECMO, carbon dioxide removal, APRV, targeting negative balance. Okay. Doing bronchoscopy in order to, if possible, to see what if there is anything can be cleared out. If there is empyema, we can. If doing a CT, if there is empyema, we can drain. If there is hemorrhage, we can do a bronchoscopy too, and to detect from where does the hemorrhage come from, and try to treat the site of hemorrhage, for example. And of course, you have to mention this should be include a senior pulmonologist and a thoracic surgeon as well. So always try to show them that you are safe and you are not working alone. You are working in a team, and you know your own limitations, and you know when you are going to ask for help. That's all the exam about. It's not about your knowledge. It's about to demonstrate your safety and your ability to work within a team. Okay. It's not a one-man show.
Yes, sir.
So,
sir, can you mention the name of the restrictive treatment strategy, the trial name?
What?
PAC trial.
Sir, can you write in the chat box? Sorry, I cannot
I
hear.
I write it, but I don't remember the name now. The name, but someone said it
So
already.
fact trial.
Fact
Trial.
trial.
Yeah.
FACTT. Fact.
FST
trial?
double T.
FAC
FAC.
double T.
Double T. Okay.
Thank you.
Thank you. You're welcome. Now, as mentioned by Dr. Who suggested CT? Someone suggested CT after intubation before taken to the ICU. Who was that?
That was me, yeah.
Who is this? Sorry? I
Karthik.
cannot see the name. Sorry?
Karthik.
Karthik. Okay.
Yeah.
Karthik. Now, because you are the one who suggested it, we followed your recommendation. After we intubated the patient in D&D, we took him to the CT before transferring him to the ICU. So, would you mind demonstrating? Tell us what can you see in this CT, please?
There are multiple huge cavities on the bilateral upper zones and ground glaze opacities as well, distributed almost throughout.
Okay.
Yep.
So, what do you think the causative organism here?
Could be fungal cavities, and also could be tuberculosis as well, because it's on the right upper zone, which is more common for tuberculosis.
What else? Fungal like what? What kind of fungus?
Aspergillosis.
Aspergillosis, great. What else?
It could be candida, though it's rare for candida to cause.
Okay, okay. The fungal aspergillosis, candida. What other infectious organism? What other infectious organism other than fungal?
Atypical organism. Atypical organism.
MRS.
Staph aureus.
Yeah, Staph aureus can cause cavities. Yeah.
Okay, what kind of Staph aureus is it?
Methicillin
Is it
resistant.
PVLA?
PVL.
Okay,
PVL.
that's the
Plantar variant.
PVLG. PVL toxin.
PVL toxin. Yeah.
PVLA. Okay. That's great. Sorry, I'm just. So, after doing the CT, any changes in the empirical antibiotics are you going to apply here?
So for MRSA cover, I would definitely go for linezolid rather than vancomycin, because sometimes PVL strain can be resistant to vancomycin.
What else other than linezolid?
And then antifungal, I would probably go for liposomal amphotericin B as well.
Okay.
Or voriconazole.
Okay.
Or voriconazole, yeah. And
what else? What other antibiotic are you going to give other than linezolid and amphotericin?
BLI.
Yeah, usual gram-negative cover like tazozin or tazozin maybe.
Okay. Okay. After 1 day culture and PCR suggests Banton, Valentine, Leukocidin, or BVL Staphylococcus aureus. What changes are you going to apply for your management?
I would get a thoracic surgeon input just in case, because we're already covering with the right antibiotic to see if something else can be done to drain the infection from the cavity maybe.
What else? Any changes in antibiotic regimen based on this culture?
We can think for clindamycin.
Who's answering? Who said clindamycin?
So myself, Pankaj.
Pankaj, why are you going to choose clindamycin?
Because it will cover the toxin of the pentan-valentin glucosidine.
Well done. Okay, that's good. What teams are you going to consult to refer this patient to?
Infectious disease team, ID team.
Infectious disease, and who else? Pika. Okay, you can go on Pika from now. Yes. Infectious disease. What else?
Sir, I would like to seek BMQ coefficients, minimal inhibitory concentration of all the antibiotics, and which is the most specific for that So I would like to have a discussion with the ID specialist regarding the
And
MR.
the idea was doing this, or the microbiologist was doing this?
It's some microbiologist only, sir.
Okay, so microbiologist. So the ID first, and then we're going to ask as well the microbiologist. So, and in some countries like UK, for example, sometimes they are double qualified. The microbiologists are qualified as ID and vice versa as well. But it's not the same in any other, in most of the other countries. Most of the other countries, ID is subspecialty after internal medicine, and microbiology is just a lab medicine. They are not involving too much in clinical. But others here, like UK, the microbiologists, some of them have got clinical qualifications as well. And vice versa, some ID have got some microbiologic or virological qualifications. So it's so in order to be always in a safe side, because every country has its own system, we'll ask both ID and microbiology. Okay. Any other teams you want to consult here? You said thoracic surgeon. The PCAS, sorry, Berjak mentioned thoracic surgeon. So thoracic surgeon. Sorry.
Pulmonologist.
Pulmonologist, great. Who else? Okay.
Well,
what complications are you anticipating here?
So,
okay, pneumothorax.
because
Pneumothorax is very likely because of those large villi.
Okay, Dr. John, let's someone answer. I know that you are very enthusiastic, but and I respect that actually. But can we say someone answer? Who is the lady who's answering now? Who's
me, sir? I was answering.
Okay.
So because there are cavities in the upper lobe, so we can suspect complications like pneumothorax could happen, or also there was a fluid overload because of pink frothy sputum, so we can suspect that also.
Hemoptysis.
Hemoptysis.
So we can also think for necrosis of the lung because of this pentanvaletin leukocidin. So in the latter half, we can also think for lobectomy for the necrotizing part of the lung.
Lung abscess.
So the lung abscess, there may be
lung abscess, empyema. That's great. That's it.
Empyema and multi-organ dysfunction.
Just to review, antibiotics, what we start, always mention, as I mentioned, always say some sort of words that they like to hear from you. Always give a title for your answer. Shine, rise and shine. Just don't mention antibiotics without saying something that you would like to hear from you. What they would like, I'll review the hospital's policy and protocols and follow the antibiotic stewardship. Okay? Always start your answer with this. I review the hospital policy and protocol. Every hospital here in Europe have protocols and policy regarding most of the infections. So, for example, necrotizing fasciitis and BVL is one of the types of actually BVL necrotizing pneumonia is a kind of internal necrotizing fasciitis actually. So except for that necrotizing fasciitis taking the skin and subcutaneous tissue, and this is for the lungs or the internal organs. So actually always say something they would like to hear from you. So always review the hospital policy and protocols, microbiology and follow microbiology and MDT discussion with the microbiology and infectious disease. Okay, this is always the title of your answer, and then you can say whatever you want to say. Linus Reed preferred, just like the doctor said. Who said Linus Reed is preferred? Sorry,
that's Karthik. Yeah,
Karthik. Well done. That's when Linus Reed preferred, actually, because of its less resistance profile, and in addition, it has much higher lung penetration. It has much better lung penetration actually than the vancomycin. For example, if it is septicemia, no, the Linus Reed is not the preferred here because it doesn't have it's not recommended against septicemia because vancomycin here is better for any kind of gram-positive septicemia. But for the lungs, regarding penetration, Linus Reed is much more preferred. Clindamycin, as mentioned by Pankaj as well, should be added here to inhibit toxin production. Linus Reed as well has antitoxin effect, but because it is a very severe infection and very highly virulent organism, and it can with very high mortality rate, they are treating it very, very extensively. Okay, So
I would also
and
involve
very
the interventional
aggressively.
radiologist for hemoptysis if they can do some kind of
If
broad
the bleeding cause
Yeah.
any kind of hemodynamic instability or become uncontrolled or HB drop, at this point we'll go with the interventional radiology as well. Well done. I forgot to mention this. Well done. Very good. And then broad gram-negative cover, example, piperacillin, tazobactam, or meropenem until culture sensitivity return. Yes, now the PCR and the cultures after 1 day, maybe it give you now that most probably you are dealing with BBL, but the culture sensitivity takes at least 48 hours. Okay, so don't stop the gram-negative until you have clear recommendations from the microbiologist or the infectious disease that we can stop them. Okay, because obviously can be a concomitant infection, or we cannot rule out gram-negative organism yet. Okay.
So as the patient is suffering from the thrombocytopenia, so in this case, linezolide will be
it's not a
best
preferred.
choice.
I know, but it's not. He's not yet critical thrombocytopenia. He's not less than 50 yet.
Okay.
He's not less than 50 yet. I agree with you. I understand, but it's not. But all of them can cause thrombocytopenia as well. Piperacillin, it's not as severe like linezolide. I agree with you. It doesn't look bone marrow suppression as well like linezolide, but in this we can start with it as well and see the trend. If the trend is still going down at this point, after discussion with the microbiologist, we can either alter it or change it something else. Okay, but at least for now, because it's acute and we don't have the culture sensitivity yet, we can use the linezolide. The complication, as you mentioned, he already has one of those complications. He has severe ARDS, he has refractory hypoxemia, he has septic shock with multi-organ failure. There is AKI and there is bone marrow suppression as well, and he's bleeding. So already, always start with the complication that he has got. You mentioned everything else and you forgot that he has got already ARDS, he has got already septic shock. In addition to cavitations, emphysema, abscess, and pneumothorax, like we all mentioned, and massive hemoptysis with airway compromise. Okay. Sometimes I know that they ask you, they might ask you questions that you find that you are repeating yourself, but don't be shy of repeating yourself. There are no negative markings. Actually, maybe if you don't repeat yourself, you will not take the mark, because as I mentioned, they are checking boxes. They are checking boxes in front of them. If you don't mention severe ARDS and refractory hypoxemia, if you don't mention septic shock, they cannot give you the mark for this. You mentioned everything else, but you didn't mention the ARDS and septic shock, which you already has got. You mentioned it at some point in the early stage of the question, but we might be asked to mention it again. Okay, so don't be shy of repeating yourself. There are no negative markings here. Okay. Referrals, as you mentioned, all microbiology, infectious disease, pulmonology, local health authorities, because it's most of the European countries, it's reportable disease, and ECMO center. What are the, I'm not going to speak about ECMO here now. I'm not going to, because ECMO needs some sort of longer lecture more than 1 hour. But I'm just going to mention now when are you going to refer the patient to ECMO according to the European standards or UK or especially the British standards. And because obviously the ECMO centers in Europe are scarce. For example, in whole UK, including Wales, Scotland, and England, and North Ireland, there are only 5 ECMO centers. Okay, and in every other country, you'll find only 2 or 3 ECMO centers in Europe. Except, for example, in Germany, which they have a much more, Germany and Italy, maybe they have more than this, or in France as well. And that's why there are always every country has its own referral protocols or guidelines. We are not required to know all of this, but at least take an idea about them. When are you going to refer the patient to ECMO? The most till now, although it's very old trial, it's Caesar trial in 2009, and now there is a newer trial, what's called Epolia trial in 2018. They made some sort of referral criteria to when to refer the patient to ECMO center. This referral criteria still applies till now. Yes, during the COVID pandemic, it changed a little bit and they included something else, because there were a lot of patients referred at that time, so they included it and altered it, especially in UK, but still the baseline of this criteria applies, because which is lung injury score more than 3, which includes PF ratio, consolidation of chest X-ray, PEEP, and compliance. Uncompensated hypercapnia with pH less than 7.2. Reversible pathology that should be reversible. No underlying life-limiting comorbidities. The patient is not DNA CPR or any limitation of treatment. For example, young, healthy patients before. Patients must have failed optimal conventional management. That means that, for example, conventional management has changed now from 2009. In 2009, prone positioning was not a conventional management, but now it's a conventional management. Any patient with ARDS, you should have tried prone positioning with him before referring him to the ECMO center. So patient must have failed optimal convention, including proning, which advised when advised by the accepting center. Okay. Of course, here there are some changes which applied recently in the last couple of years. It was mainly because of the COVID pandemic, including clinical frailty score. This clinical frailty score, for those of you who are not aware of it, it's a score to assess the functional background or the physiological background of the patient, and usually it applies to the patients who are above 65 years old, but it can be applied to anyone else, but usually it's applying for the geriatric patient, but can be applied as well to even to young patients. For example, if the patient is bedbound or is bound to a wheelchair, this can be applied clinical frailty score. Clinical frailty score 1 is very healthy individual, going to the gym, doesn't smoke, doesn't drink, doesn't have any health issues whatsoever. Clinical frailty score of 2 is just like us, like all of us. Maybe if some of us are smoking, some of us are drinking, some of us have got hypertension or diabetes or cannot or don't go to the gym or a little bit overweight. Most of the humanity, whether young or old, are clinical frailty score of 2. And then there is 9, which is very almost dying and death is imminent. And then there is 3 or 5. So most probably this young gentleman was before clinical frailty score of 2 because he was smoking, for example. And then what's called RESP score. RESP score is for VV ECMO mainly for patients who have got ARDS and has multiple variables, including age, immunocompromised status, diagnosis, duration of mechanical ventilation, neurological status, peak in inspiratory pressure, peak, not plateau, cardiac arrest history, if there's a history of cardiac arrest. And the scoring is ranging from negative 22 to positive 15. Whenever you are negative, that means you are a very bad prognosis. Whenever you are positive, that means that you have a better prognosis. So usually, if 1, that means RESP score of 6%, that you have very favorable survival rates, 92% that most probably are going to survive. And then score 3, negative 1 to 2, 57%. That means 50-50. Most of the ECMO centers, especially in UK, usually don't accept higher than 3. They don't accept 4 or 5. Okay, they usually accept patients in this respiratory score, especially if they are dealing with patients with ARDS or pneumonia, that they are referred only for VV ECMO. Regarding VAV ECMO or VA ECMO, which is being for cardiology or cardiac diseases, it's a different story. This RESP score only for VV ECMO. Okay? Don't get confused with the VA ECMO or VAV ECMO or VVA ECMO. Okay? This is only for VV ECMO. And these other scores which are used as well to preserve for the ECMO in general, Murray score for ARDS severity, RESP score for ECMO survival prediction, VV ECMO survival prediction, preserve score, mortality risk in ARDS on ECMO, and SAVE score. This is for the VA ECMO. This is the one for VA for the cardiogenic patients. Okay, this is the only one which is used to assess whether the patient can get benefit from the ECMO or not. But actually, because currently I'm working in an ECMO center, no one uses it actually. So it's only about whether the patient is a candidate for transplant or not, or whether the patient's young, whether young or not young, whether they are a candidate for transplant. Usually they put them on VA ECMO, or patient was in VVV and he's deteriorated, then and they developed cardiomyopathy, then they are going to put them in VA ECMO as well. So he would if he has got arterial cannula in addition to the two venous cannulas for the VV ECMO, it's called VAV ECMO or VVA ECMO. Okay. That's it. I'm not going to talk more about ECMO here because it should be, because I'm not the best person. I'm not an expert in ECMO to talk about it. That's one. Secondly, because it is not, we don't have time and it can take a whole lecture by itself, especially regarding the troubleshooting in ECMO. Okay. Let's carry on with our case. Who wants to carry on? Any volunteer? Just raise your hands, please. Any volunteer? Anyone would like to carry on with the case? Hello?
Okay.
Jagan? Okay, Jagan?
Uh,
Jagan, okay. Jagan, you raised your hands. Okay. Would you like to go on?
Yes, sir. Yes, sir.
Jagan, okay.
Hello. Yes, sir.
Yes, sir. I'm here. Jagan, are you Jagan? Because I cannot see
Yes,
the
yes,
all the
sir. Yes, sir.
participants. Okay. Okay. Would you
Yes, sir.
mind carry on with the scenario, please? This is the
Yes,
same
sir. Yes,
patient.
sir.
This
Yes,
is the
sir.
same patient. Okay. Yes. Would you mind reading this the vignette, please?
On day 5, the oxygenation started to worsen again after initial improvement due to proning associated with high fever.
What's your definition of could you read the numbers?
Yes, sir. The ABG shows a pH of 7.08, PaCO2 of 29, PaO2 of 10.2 kilopascals, bicarb of 9, and a lactate of 12. Potassium of
Sorry, 10.2
6.3,
kilopascal means about 70 something, 70,
70.
75, yeah.
Okay, sir.
I'm sorry. Yes. And
Sodium of
triglycerides of
138,
20,
urea of 15.
triglycerides of 20 means 2000 in milligram per deciliter.
Okay, sir.
Okay, triglycerides of 20 means 2000 milligram per deciliter.
Okay.
Okay, so what's your
Hypertriglyceridemia,
definition?
troponins were elevated.
Okay, what's and what's your comment about the ECG?
So this could be propofol infusion syndrome.
Okay, why?
Because this is metabolic acidosis with hyperlactatemia and hypertriglyceridemia.
Who's this?
Also,
Who's answering, sir?
I'm Priyanka. Sir.
Priyanka, yes. Well done, Priyanka. Okay. So what are you going to do next, Priyanka? And what else? What other signs of propofol infusion syndrome you can see?
Elevated lactates, elevated triglycerides, and
kidney injury is aggravated, elevated tropi,
Okay,
And then
kidney injury
severe
aggravated.
metabolic
T-wave
acidosis
inversions.
with
and
acute kidney injury.
With acute kidney injury. But why don't we say that this maybe happens due to the acidosis, to the progression of the acute kidney injury? He already came with acute kidney injury of 2. Why we don't say it might be due to the medication effect or due to the progression of the primary disease?
there is
sir,
also liver dysfunction and high
lactates
TZ.
and triglycerides.
Okay. What you can see in the ECG?
ALT.
OLT as well, yes. What can you see in the ECG?
T-wave
and
inversion.
inversion
Prolonged QT interval
and
Lung QT.
And what else?
and T-wave inversion.
and peer no.
Okay. Well done. Priyanka, you are impressing me every time. So what are you going to do next?
So first I will manage hyperkalemia because it can be life-threatening. So I will give calcium gluconate 10 ml over 10 minutes and glucose insulin drip and try to reduce the potassium levels. And then I will stop the propofol infusion, which is leading to this manifestation. And because pH is very low, I can consider starting maybe a sodium bicarbonate infusion in this patient. And lipid, I can consider giving intralipids also because they act as a lipid sink and maybe reduce propofol.
You're going to give interleaved as well.
Yeah.
Okay. So what any investigation would you like to do to this patient? Any other investigation any of you would like to do?
CPK level.
Just one investigation.
CPK.
CPK, exactly. Well done.
Do to the echo.
Yes, CK. CK is 42,090, more than 42,000. Exactly. So we have got a rhabdomyolysis. Okay. So just a few words about propofol infusion syndrome. It's it's a life-threatening condition, which is characterized, as you mentioned, metabolic acidosis, rhabdomyolysis, hyperlipidemia, enlarged or fatty liver. The pathophysiology is poorly understood. Maybe direct mitochondrial respiratory chain inhibition or impaired mitochondrial fatty acid metabolism. Clinical features: high dose, long duration propofol infusion, usually above 4 mg per kg per hour, increasing inotrope support, green urine, but this is not a feature of propofol infusion syndrome. This is a feature of propofol in general. Anyone who has been on propofol for a long time in ICU will find them with a green urine, okay? Or cardiovascular collapse. Risk factors, of course, younger age. Propofol maybe above or equal 4 mg per kg per hour, and maybe even less than that, especially if it has, because it's usually due to the accumulation of propofol other than the dose itself. Because, for example, in the theaters or in the surgeries OR, the anesthetists use very high doses of propofol with the TIVA, for example, but it's for short period of time. But here, because you are using those for prolonged period of time and via continuous infusion, that's why you develop this kind of syndrome. And that's why I wanted you, Priyanka, to tell me that he was in a very, I mentioned in the beginning, if you remember the vignette in the first slide, the patient weight was 60 kilos and height was 160. And then after when we initiated him on propofol, I said that it was written that propofol with 240 milligram per kg per hour. So usually some numbers are really distracting, but they are not going to mention the weight and the size or the size of the patient or the height of the patient for nothing. It should have carry on some sort of indication of something. Okay, so usually they don't write the doses of the medications he's on, but when they write the doses and they write the height and the size and the weight of the patient, there should be something here hidden in the scenario that they want us to track. You are good that you diagnose the condition from the triglycerides, but triglycerides and lactate can be HLH. The patient might develop HLH, Priyanka, right? He might be HLH. He has got severe infection. He's a young patient, and he's getting worse, and he becomes febrile again. This might be indication of LHLH, right? You could have asked me if we can do ferritin as well, and or CK, right? It can be HLH, for example. So I always try, when they are going to ask you why you are suspecting propofol infusion syndrome, answer should be a little bit more pragmatic answer, that there are multiple causes which let me suspect propofol infusion syndrome here. He has been on it for 5 days. He has been on it for long doses. He is a very underweight. He's getting very high dose of propofol, and he's very underweight as well. Or not underweight, he's a very small person as well. So he has got all the risk factors for propofol infusion syndrome. Investigation, if you see the ECG, you will find that there is some sort of elevation in the ST segment. Look at V1 and V2 and V3, sorry. There's some sort of elevation. It's not a classical elevation, but this is from a patient with propofol infusion syndrome, okay? And this patient was one of my patients, actually. And actually, then after he died, they asked me to review his mortality and presented in the mortality and morbidity meeting. I found that this patient, the cardiology have been treating these changes and the increased troponin as a type 2 MI. Okay, and they started him on aspirin and anticoagulation because they interpreted this kind of findings in addition to high troponin as type 2 MI, especially that he had ischemic heart disease before, but was under control. Okay, and then no one have noticed that he was propofol infusion syndrome till 2 days before he died, because no one noticed that the triglycerides were rising exponentially or trending. The trending is rising. No one noticed this. That usually in most of the ICUs, the triglyceride is being checked at least either every day or every other day, and especially when the patient is on propofol. And no one thought, even after they spotted it out and they discovered the triglycerides are very high and they stopped the propofol, no one thought about checking the CK. And the result is that the patient died most probably of propofol infusion syndrome, because no one spotted the increase in triglyceride, and no one, after even they spotted it out, for 3 days, no one checked the CK. And they were attributing the deterioration of the patient condition and the AKI to the pneumonia, to the septic shock, and to cardiogenic element due to MI, type 2 MI. No one thought about propofol related infusion syndrome. Okay, because it's a clinical diagnosis. No one investigation will give you the right answer. It's a clinical diagnosis. You have to, it's a puzzle. You have to gather the pieces together in order to reach the whole picture, because triglycerides can be increased in a lot of things. Okay, a lot of other issues. And does it mean that he has got propofol infusion syndrome? He might have got pancreatitis, for example. The incidence of propofol-related pancreatitis is at least 10 times or 20 times more than propofol-related infusion syndrome. The main reason we stop triglycerides when the patient is on propofol, not because of propofol-related infusion syndrome, because of pancreatitis. When the triglycerides are above 1,000 or 11 by millimole per liter, the incidence of pancreatitis is about the third, 30%, even if it is subclinical and not manifested. But the incidence of propofol infusion syndrome is far, far less than 1%. Okay, so be mindful of that, because it's I made it a little bit complicated here because this might happen. They might the scenario. The vignette might be starts with pneumonia, and then it may take to any other pathway, any other complication which the patient might develop in the ICU. He might develop pancreatitis after this pneumonia. He might develop HLH after this pneumonia, and he might develop what is less common, PRES or propofol-related infusion syndrome as well. Okay, and this always happens in the long cases. The patient starts with diagnosis but develop something else while he's being there in the ICU.
Please, what is HLH?
HLH is hemophagocytic lymphocytic histiocytosis syndrome. We had a session about it a couple of weeks ago, or last month. I think last month. Yeah, we had a session about it. Just to review the session, please. It was a long case as well, and we discussed it in detail. It's a very common issue now. Obviously, it was underdiagnosed in the past. It was not very common term, but now recently the acquired HLH, it was mainly rare hematological condition, usually can be inherited or acquired. For some reason, the incidence or prevalence of the cases now have increased a lot, and over the previous few years. I'm not sure why, but in addition to this, the interest of the examiners, whether in the EDIC or the FECAM or any other ICU exam, they become very interested in bringing it as well in their exams, whether theoretical MCQs or short cases, or sometimes long cases, or VIVA exams as well. So, and it came last time in the last exam, last May, it came as well. HLH came as a short, as a CBS. So if it's come as a CBS, if you brought this HLH as CBS, they might bring it at some point as a short case or long case in CCS as well. Okay, clear, Dr. John?
Yeah, thank you, sir.
Thank you. Any questions so far? And of course, Priyanka, I cannot find any other management regarding. Sorry, Priyanka. So the Brugada infusion syndrome, blood gas, laboratory, lipids, UND, CK, propofol levels, or chromatography, which is usually, if available, usually it's very rare to find a hospital with which will look for propofol levels of chromatography. I'm working now in a university hospital in Manchester, but I have never seen someone asking for propofol levels actually. This is a classical Brugada syndrome. This is a textbook or classical Brugada syndrome, which you find elevation of ST segment in V1, V2, and V3, and prolongation of QT, and those patients are in high risk to develop ventricular tachycardias. And that's why they usually prophylactically insert ICD for them, intracardiac defibrillators. But of course, you are not expected to find this classical in the patients with press. Usually they will have some sort of elevation, they will have some sort of deviation, but it will not be a classical Brugada-like syndrome, okay? But in the exam, they might, to make it easier for you, they might bring the classical Brugada-like syndrome. I brought an actual case, and I'm sorry for this, but in the exam, they might bring a Brugada-like syndrome like this to to make it easier for you, that it's a propofol infusion syndrome. Management, high index suspicion, that's the NIH. I'd mentioned by Priyanka, stop the propofol. The first thing is to stop the propofol immediately. Okay, don't wait to confirm the diagnosis. Immediately stop the propofol. Monitor for early warning signs, lactate, CK, urinary myoglobin, ECG. Discontinue propofol immediately. Supportive care and monitoring. Consider pacing if the patient has bradycardia from this. Adequate carbohydrate intake, which should be with dietitian. Carnitine supplementation, theoretical, not clinical. Hemodialysis and perfusion. And this is the most useful and the most used management so far for propofol infusion syndrome. And of course, sometimes ECMO, whether usually VAV ECMO, which is venous arterial and or VV or VAV, which is veno-venous arterial or veno-arterio-venous ECMO. Priyanka, I have never read about giving interlipid for propofol infusion syndrome. Okay, Priyanka, are you with me?
Yeah, yes.
I don't know from where do you bring it. It's not. I don't think I'm not saying it's wrong, but it's not logic actually. Someone who has got lipemic serum and triglycerides are high, to give him intralipid.
Intralipid is used for local anesthetic toxicity.
Local anesthetic toxicity, and is used for tricyclic antidepressant toxicity, and sometimes for other toxicities as well. But it's not a classical antidote, but at least it will reduce absorption of the medications like local anesthetics or tricyclic antidepressant. But I have never seen someone mention or say to give interlipid for propofol infusion syndrome. If you have a resource for this, I would be very appreciative if you can send it to me. Okay?
I think I got confused maybe.
But maybe not. Maybe you read it somewhere. But I'm not saying you are wrong, but it's not logic. It doesn't seem logic to someone has got lipemic serum and triglycerides, very high triglycerides, to the extent that you cannot give propofol to give him intralipid. But maybe you read it somewhere. I don't know. But propofol infusion syndrome cases are very rare. There are no guidelines for it. It's our only case series. All the propofol infusion syndrome cases in the literature are case series. Okay, so because they are very rare, and all the management would differ from a place to other. There is no consensus about how to manage propofol infusion syndrome. Okay, so I think we run off time, but we have to run a little bit faster. Okay, who's going to have the next question? Any volunteer? Anyone would like to raise his hand at least?
Yes, sir.
Who is this? Who is it? Pankaj?
Pankaj,
Anyone else?
Yes, sir.
Anyone else other than Pankaj would like to answer? Because the answer, Pankaj, I can understand Pankaj and John are very enthusiastic, but would like to give a chance to someone else.
Sir, I can answer.
Who is this?
Priyanka.
Priyanka again? Priyanka already answered. I need someone other than you three. Okay.
Sir, can I?
Who is this?
Nafiza.
Nafiza. Okay, Nafiza. What CRT settings are you going to use to treat this condition and mitigate the acid-base balance and the electrolyte disturbance?
So for this patient, I would prefer for continuous venous hemofiltration.
So what else? So they are going to use the modality of CVVH, right? So
Yes.
what are the settings are you going to use here?
So yes, settings for the CRT.
Yes.
What are the for this patient? I set the blood volume as start for the 50 to 100 ml per minute. Dialysis rate is about 100 to 200 ml per minute, and dose of the CRT will be 20 to 20 ml per kg per minute, and ultrafiltration will be sorry, I forgot the exact dose. And I also prefer the regional anticoagulant for this patient, like regional citrate anticoagulation.
Yes. And what else? Okay. So as mentioned, we'll always say we are going to start our answer, we'll follow the hospital policy. Okay. And then modality, either CVVH or CVVH-DF, both can be used. Okay. CVH-DF usually its advantage that combines convection for myoglobin and middle milk plus diffusion for small like solids like potassium lactate, but CVH can be as well. It's whether this or that. Dose and effluent flow. This very arguable statement is to start with a high dose 30 to 35 is very arguable statement, especially that maybe the hemodynamics of the patient wouldn't allow you to do so. But to be on the safe side, you can say 25 to 30. 25 is always acceptable to anyone. But if you want to increase, you can mention higher dose, for example, 25 to 30, and maybe start with the higher dose if possible. Okay, this is arguable statement, but at least you can to be on the safe side, say 25 to 30. Okay. Blood flow rate, as you mentioned, 150 to 200, which is neither cause hemodynamic instability, will not cause drop in blood pressure, and at the same time is not that slow to cause clotting of the filter. And dialysis replacement fluid, usually we cause bicarbonate-based buffer, not lactate buffered, as patient is already has severe lactic acidosis. Potassium concentration in the replacement dialysate should be tailored according to the patient need, whether 0 to 2, according to the hospital policy and protocol. Usually, if you ask any nephrologist or renal, 2 is can be as long as the patient doesn't have very high potassium above 7 or 7.5. 2, you can start with 2. But now most of the hospitals have some sort of protocols of policy. We will go with the hospital protocol of policy according to the potassium serum levels. Okay, and the nurses usually who are managing this according to their policy and protocols regarding the dialysate fluid or the replacement fluid. Clear? Clear. I know that not all of you are experienced with the CRRT, and you can make another lecture about. We are going to just explain the CRRT, but just take it as it is for now. That usually the CRRT is about the first modality, dose of the infiltrate or the replacement fluid, blood flow rate, and the type of fluid you are giving, and whether the content bicarbonate-based buffer or lactate-based buffer, or the potassium content in the replacement fluid itself. Okay. One day, maybe we can make a special. There is a very good lecture about CRRT in Farz Academy website. You can review it, and if you want, we can make another session about CRRT itself by itself. Anticoagulation, as mentioned by Nafisa, regional citrate is always preferred in most of the cases. Sometimes it's contraindicated in severe liver dysfunction. Unfractionated heparin, if citrate is contraindicated, this patient has got some sort of. If the when he presented with blood-streaked sputum and thrombocytopenia. If this has improved, then we might use heparin, but usually citrate is the best because citrate, the complications of citrate are much less than that of the heparin, but it needs training for the nursing staff. So it's according, and that's why I always start your answer by follow the hospital policy and protocols. Follow the hospital policy and protocols. If you cannot give neither citrate nor heparin, then we might do the filter without anticoagulation as all. But at this point, it's better to do what's called pre-dilution dialysis. Pre-dilution means that the replacement fluid is going to be before the filter, not after the filter. This is difficult to explain without diagram. I can bring the diagram for you if you want, but it will reduce the quality of dialysis a little bit, but at least the issue, just take it as it is for now, that you can use the filter, you can use it without heparin or citrate if there is a contraindication to citrate or contraindication to heparin, either. And if better to prevent clotting or clogging of the filter, better to make it pre-dilution dialysis. Pre-dilution might reduce the quality of the dialysis a little bit, but at least it's a safe option and the cost effective as well. CRRT is a very, very important subject in the exam, whether in CBS or CCS. And usually it's just like PICO, okay? There is no exam without PICO or without CRRT questions, okay? So always to be, at least, please, after we finish, you can, if you don't work with the CRRT in your hostel, just review the CRRT lecture, which is on the Farz Academy website, please, because it's a very good lecture actually, and very detailed lecture. And of course, other consideration: monitor electrolytes, phosphate, calcium, magnesium, adjust dialysate composition as required, and remember that CRRT itself is not clearing propofol, but it's managing the metabolic derangement which happen due to the propofol. Okay, and sometimes we'll have to go to advanced therapy like VAV ECMO if it is feasible, in your hospital, or if they accepted him. Now, who's next? The last question. Because this is a very important question, actually. Who wants to take the pleasure of having the last question?
Citrate toxicities.
There is a citrate accumulation, as there is a metabolic alkalosis.
Who's
Nafisa.
Okay, Nafisa. So, what you can see from this?
So this is a metabolic alkalosis, and ionized calcium is low, and total and ionized calcium ratio is 2.25, that is less than 2.5. It is citrate accumulation.
Early or late? Is it early or late?
I have no idea, sir. What is early and late? I have no idea.
Who wants to answer this question? Early or late citrate accumulation?
I know about cytotoxicity and citrate accumulation, but early and late, I know. I didn't.
It's early citrate accumulation
only,
because
sir.
of alkali load, sir.
Accumulation is early and toxicity is late.
No? Yes, sorry?
It's early citrate accumulation, sir.
Accumulation is early, toxicity is later.
Also, in severe, the ratio will be more than 2.5. Here it is 2 to 2.5. So that's why it's not.
So it's early citrate accumulation because the patient is alkalotic and there is only hypocalcemia. In late citrate accumulation or citrate toxicity, when all the buffers of the citrate have been already consumed or saturated, then you will find that the pH started to acidosis, high anion gap metabolic acidosis. The patient will develop high anion gap metabolic acidosis in the late citrate accumulation, or what's called citrate toxicity. And that's why this is an early sign that we have to act early before the patient develops citrate toxicity. Okay? So what are you going to do now?
So for this patient, I like to prefer this measure the serum calcium level again and correct the serum calcium level. And for the accumulation, I increase the decrease the blood flow and increase the dialysis or predilation of fluid the rate.
So what about the citrate? Are you going to use the citrate as well?
We will stop citrate and resort to other anticoagulation.
So, sir,
More
sir, in case of accumulation, should I stop the citrate, or in case of toxicity, should I stop the citrate?
Very good question. Anyone would like to answer?
As I know, in case of toxicity, we should stop the citrate. Otherwise, we can follow the decreased blood flow, or in case the dialysis flow rate, that will enough, and also correction of the calcium.
Okay. This is dependent about the patient's condition itself. So if the patient has got some sort of hepatic impairment, okay, or hepatic failure, then you don't expect that his citrate or his condition will improve when you continue with the citrate. Okay, so yes, because obviously we have been trying now to chelate the citrate via the calcium. Sorry, to neutralize the citrate via the calcium, and has been being done for a while now. Okay, and obviously still, and we have increased doubled the dose of the calcium, from 2 to 4, and still the patient is accumulating. So don't expect that the patient, and obviously has got some sort of hepatic impairment and multi-organ dysfunction. So don't expect that citrate will improve. You can say this. I'm not saying it's wrong answer, but whether if your patient has got early citrate, either you can say either stop the citrate and look for another option, or you can say I will follow the hospital protocols, I will follow the hospital policy. Either I'm going to, whether it's going to follow it closely, and if the patient is not improving, I will stop it, or I would stop it and use other alternative. Okay, so it's some sort of both answers can be accepted here. There is no yes or no. Okay, so both answers can be accepted. There is no yes or no. Always try to be on the safe side. I would follow the hospital policy and protocols. If the because here it's we are in a gray zone. We can either stop it at all and seek an alternative, or we can continue and follow it and observe it closely. And I might ask advice from the renal team or nephrology team as well. Okay, so always try to show them that you are a very safe doctor here. Okay, so in this kind of question, there is no good answer for it. They are expecting more than one answer. Okay, and by the way, this question came last time, but it was hepatic failure case. It was post-hepatectomy case. The examiner asked me, the patient had high lactate and had hepatic failure. The examiner and the patient had a lactate of about 4 or 5, about 6, 5 or 6 or 8, something like that. Because I'm working in a center where there is a lot of hepatectomies being done and a lot of hepatic failures, hematobiliary team, I discovered by chance that it is written in our policy that don't use citrate to anyone who have got lactate above 4. This is in our policy. This is in our policy. It's not scientific fact. It's not guidelines. This is our policy. Don't use citrate to anyone who have lactate above 4, because here there is a high risk of citrate accumulation. This is our policy, and you have to comply to it, even if it is not based on a solid evidence. So when the examiner asked me about this, I told her, of course, I started my statement with follow the hospital policy. She said, okay, what are your hospital policy? And then I mentioned the settings which I would use. And then she came and I said, last thing I said, I'm not going to use citrate here because the lactate is high and the patient has got hepatic failure, which might lead to worsen of citrate accumulation and worsening of the condition. So she told me why the citrate accumulation might happen here. So I wanted to mention the biochemical pathway, and then I started my answer with, it is a defect in Krebs cycle or citric acid cycle. So once I said Krebs cycle, she stopped me. She told me, that's enough. I don't want you to continue anymore. That's enough. Okay? Because I said the word that she was looking for. And then the scenario went by. The patient took citrate. Although I said I would not use citrate, but according to the scenario, written scenario, he had citrate, and he developed citrate accumulation. And this was the picture. He started to be alkalotic and hypocalcemic. Although he has got, initially had hepatic failure. And she told me, what do you think this have happened here? So I told her that is now it's early citrate accumulation. It's a citrate accumulation. So how we are going to answer how we are going to treat that? I told her I will stop the citrate. I will use the heparin if it is not contraindicated or not risk of bleeding, or use what's called use the filter without heparin or citrate and use a pre-dilution dialysis or shifting to SLED if the patient hemodynamically could tolerate the SLED, which is slow, efficient dialysis, which is being done by a normal dialysis machine, but it's being done over 12 hours instead of 3 or 4 hours. Okay, this is my experience with the exam, and this kind of questions they are expecting you to answer, because the CRRT now has become one of the it's just like the mechanical ventilator. Most of the ICUs now have got CRRT in there, whether especially in Europe have got CRRTs now. Okay, at least one or two machines. So you are expected to know how to manipulate, how to write a prescription, and how to troubleshoot the problems of the CRRT. Unlike the ECMO, for example, which is only found in one or two centers in each country. So family are asking you about the outcome. What are you going to say? This is non-clinical question. Who's good with communication here? Let's go, guys. We're running out of time. We already ran out of time. Already 4 minutes behind. Any volunteer?
So I will try to convince the family members, most likely the most next of kin, the closely related to the patient, and I will establish a multidisciplinary team meet with the patient and taking into confidence the family member. I will introduce myself and tell all the keep a transparency about all the complications which have happened in the patient, and try to explain the prognosis to the patient, giving the proper facts about that. And then I will also keep an account about the patient's emotions and empathy, and I would like to tell that the prognosis is not good, it may be grave, and the patient may not recover also. So
very good, well done. That's the issue. It's about saying the facts. Obviously, now the prognosis guarded BVL has got a mortality of 30 to 50%. Propofol infusion syndrome as well has a similar mortality rate. The case serious is between 30 to 80. So it is the range is about 50% as well of the propofol infusion syndrome. So if you combine both together, you have a very, very bad prognosis to a very young patient with no past medical history. So you should show empathy, show sympathy, and be honest. A patient has got iatrogenic complication in our ICU. And it might be, I'm not sure yet, but it might be due to the management. So you should be honest and should be transparent. And said that this is the iatrogenic complication which happens in our ICU. Okay? And it's going to be under investigation. Okay, obviously, because this is an incident, obviously, the patient has got this very high triglyceride without being investigated. Okay, and the survivors as well. If he survives, he might suffer from chronic lung damage. Okay, and chronic problems as well. Prognosis to press, as mentioned, 30 to 80. There are risk factors for poor prognosis: high prolonged infusion, late recognition, severe lactic acidosis, multiple organ failure. Okay, and the better outcomes, of course, early diagnosis and immediate cessation propofol and aggressive supportive measures like CRRT for acidosis. This a very good resource. It's one, it's not two, it's only the one. It's about case of the month. It's in the Faculty of Intensive Care Medicine. Every month they publish a case, which usually, and then with this case there is a small, for example, this case about ECMO. They might give you some small hint about ECMO, which is enough for your exam. and how to troubleshoot the problems of ECMO, which is more than enough. For example, they might give you some information about how to manage the CRRT as well. So it's only 55 cases. Every case will not take more than 10 minutes. So you can just every day you can read 1 or 2 cases maximum, and it will be very useful to you for the exam, and even for not for the exam as well. Okay, any questions? Any questions? Okay, thank you so much. Thank you for having me, and sorry, but I don't know how to manage especially in this interactive sessions, how to make it less than 1 hour. But in the exam as well, it will be 50 minutes. Sorry for it.
Time management is optimum. It's okay.
Thank you so much, and don't forget the feedback, please. And you already have got my email and phone number. Whenever you want anything, I'm more than happy to answer you. Thank you so much.
Thank you, Dr. Fathy.
Thank you, Fathy. Thank you.
Thank you, sir.
Thank you. Don't forget the feedback, please. Don't forget the feedback, please. Thank you so much.
Yeah. Okay.
Thank you, sir.
Thank you so much. No. Thank you for your participation and interaction. Thank you.
So we are concluding the meeting here. We'll be seeing everyone after the puja holidays. Thank you, everyone.